Okay, so let's get pediatrics out of the way. This is season 3 finale. Let's go. Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at exam questions in a clinical course. We are concluding season 3, especially with pediatrics. This is actually the season finale for pediatrics season 3 because we've done 2 rounds of pediatrics in this season. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment to show some support in the dark abyss of the YouTube algorithm. You already know the gist of these videos. You may pause them to scream your answers at your screen or write them down on a piece of paper so that you can count down your total at the end. Here comes question 1. Mutala, a 10-month-old healthy infant, is rushed to the hospital with sudden difficulty breathing and copious oral pharyngeal secretions. He was well until 5 minutes ago. He has no fever. On further questioning, the maid said the only thing that crosses her mind is that the house was painted the day before and Mutala was found with the lid of a container left behind by the painter in his mouth. What are you likely to find when examining the eyes of the infant? What is the most likely diagnosis? I know there's going to be a lot of debate in relation to this question, a lot of arguments and a lot of people with different ideas. But let me give you a background. Before I actually give you a background, a big shout out to Helena Liseli also for being of great help on this video. It was actually her birthday yesterday. A big happy birthday to her. And let me give you a background of lead poisoning. Now with lead poisoning, it tends to present to you with pretty much chronic symptoms. So they tend to have intellectual cognitive impairment in the long run. They may have some seizure disorders. Acutely, they may have an encephalopathy that they may present with, but they do not have these symptoms of this sudden difficulty in breathing, these copious oropharyngeal secretions. Moreover, it's can be misleading to think that a child with, of course, lead poisoning, you're expecting that if they were eating a lid, it's most likely paint. That's the assumption that most people are making. But of course, that's not really the reason. On the other end of the spectrum, we have organophosphates and carbamates that are not only just found in insecticides. Keep that in your mind. They're not only found in insecticides. They're found in many other chemicals. They're found in paint thinner. They're also found even in some paints. They are known as organophosphates and carbamates. Now, these are pretty much going to be working by inhibiting your acetylcholinesterase, preventing the breakdown of acetylcholine. Therefore, it accumulates in the nicotinic and muscarinic receptors, bringing about the characteristic features. So for us to actually be able to answer this question, we first have to establish what the diagnosis is, and we'll come back to what we expect to find when we examine the eyes of the infant. So moving on to question 1, the answer. Here it comes. So most likely this child has an organophosphate or carbamate poisoning, and this is causing meiosis because it's stimulating contraction in the circular muscles of the iris. Moving on to question 2. Walia, a 2-year-old toddler, is brought to the emergency pediatric services with a history of diarrhea, vomiting for the past 3 days. His stool is watery with no blood. On examination, he is lethargic, too weak to take any fluids orally. His weight recorded a week ago was 11 kg. Classify the child's state of dehydration. List down any 3 additional physical findings to support your answer. Lay down your rehydration plan and the fluid you would use for Walia. Write down the adjuvant treatment once the child is hydrated. So you may pause your video, and here comes the answer. So this is a child that has severe dehydration. How do I know this? The child is lethargic. They are too weak to take any fluids. So they have severe dehydration. Now, any other 3 additional features that may support my answer? Of course, the lethargy, which is already there, the dry mucous membranes, the sunken eyes. Do not fall into the trap of saying sunken anterior fontanelle or posterior fontanelle. This child is 2 years old. They have a reduced skin turgor greater than 3 seconds, a capillary refill time greater than 3 seconds. Our rehydration plan is going to be our plan C. Remember that this child is above 1 year, so we're pretty much going to be using 100 ml per kg of Ringer's lactate or our strength Daro solution. So we're going to give a total of 1,100 mils in 3 hours. How are we going to give this? 30 mils per kg in the first 30 minutes. So 30 by 11, that's 330, and 70 mils per kg in the next 2.5 hours. That's 70 by 11, that's 770. If you add these two, they give you 11,000. Or 1,100 rather, not 11,000. Then we're going to be assessing the child every 15 minutes, and we reclassify the hydration stages after 3 hours. The adjuvant treatment that we may give this child once they are hydrated is zinc sulfate, about 20 milligrams orally once a day for 10 to 14 days. Remember, this child is greater than 6 months. If they were less than 6 months, we give them 10 milligrams once a day. Now, I want you to comment in the section below. Tell me about how zinc works and the mechanism of action as to how it reduces the morbidity and mortality of diarrhea and associated diarrheal diseases. This is especially important for the final year students. So moving on to question 3, which also has some other debates. Melanie, a grade 11 adolescent, attends OPD complaining of a recurrent genital thrush, which she claimed would clear after treatment, but would resurface a few weeks later. This has been going on for the past 4 months. She is HIV negative and feeling increasingly weak lately, and has lost weight. Write down 2 conditions you would explore during your history taking. As you work out the case, you reveal the following results: WBC 13, HB 9.5, MCV 75.9, RBS 9.4, AST 39, total serum bilirubin 51 micromoles per liter. What is your diagnosis? Write down 1 critical investigation you would carry out to plan to explain what is happening to Melanie. Outline your management in 4 bullet points. So you may pause the video here. But let me give you a background here. This is a child that has recurrent genital thrush. So it means there is some sort of immunosuppression. That's why they did the HIV initially. It comes out negative. Okay? Remember that HIV is not the only thing that causes immunosuppression. Another thing that could cause someone to be feeling weak and to lose a lot of weight is diabetes. We should keep this in mind. Of course, we don't want to rule out sickle cell. Looking at the whole question and look at where this examiner is pretty much leading us towards, sickle cell would not also be ruled out. So here comes the answer. So most likely this child, you want to explore diabetes mellitus, you want to explore sickle cell disease. In some cases, some people may argue that, okay, I would also want to explore leukemias. But of course, it would explain the chronicity, the immunosuppression, but in this case, the increasing weakness, the weight loss, could be explained by the leukemia, but the blood work doesn't really point us towards leukemias. So if we look at the blood work, they have WBC that's 13. It's not surprising to have this in a sickle cell patient. We have an HB of 9.5. It's also not surprising. It could be due to chronic hemolysis, which is also manifested by a higher serum bilirubin level. The RBS is not as high enough to classify this child as being diabetic. AST shows slightly elevated. And of course, MCV is reduced. Now we want to do our HB electrophoresis or cycling test or peripheral smear. But remember that the gold standard is HB electrophoresis. So we want to admit the child, cover them on broad spectrum antibiotics and antifungals. We should give them some IV fluids, group and save, plus or minus a transfusion for this child, depending on the other symptoms that may be present. Then also cover this child on folic acid or give them folic acid. Now, Lishabel, a 3-year-old girl who presents with edema and is underweight. The following are her lab results. Urea, or just a sidebar on the previous question, the reason why I didn't add iron to that regimen is you don't add iron when you have infections. You'll make it worse. So urea 2.5, sodium 128, potassium 3.5, serum albumin 28, cholesterol 2, urinalysis showed protein 2+, blood 1+, leukocytes numerous. What 2 other important physical features should be present in this child? What is the most likely diagnosis? What other diagnoses should be considered and treated? You may pause the video, and here comes the answer. So obviously this child has edema. Okay, remember that whenever you have renal involvement, you may have edema. This child is also going to be having proteins and blood in the urine with a lot of white blood cells. So most likely it's a nephritic type of syndrome. This child has a nephritic syndrome. So remember that the triad in nephritic syndrome is your subnephrotic range proteinuria, your hypertension, and your hematuria. So they may have hypertension, they may have oliguria. The other two things that you want to look out for is malnutrition. This child is edematous and also underweight, and also you want to rule out nephrotic syndrome as well. Moving on to question 5. A 3-day-old baby is referred to the hospital from the local clinic because the mother has noticed that he appeared yellow and weak from the time they were discharged from the local clinic. These clinics be doing the most sometimes. The mother said that she was told that the yellowness would disappear with time. The baby was born by normal vaginal delivery. She says the baby cried at birth and had started breastfeeding. What is the diagnosis of this child? What other information would you obtain from the mother? What investigations would you order? How would you proceed with the management of this child? What complications would you be concerned with in this child? You may pause the video. Here comes the answer. So this child has neonatal jaundice or neonatal hyperbilirubinemia. So you want to ask about if this mother has had previous pregnancies, if they were eventful during the pregnancy or at labor, if she's had any abortions. You also want to ask about similar illnesses in the past pregnancies. You want to ask about the features of the child's stool and urine, history of any fever that may point towards infections. The stool and urine may point you towards obstructive kind of jaundice. You want to ask about the maternal and paternal blood group in the case of rhesus incompatibility. You want to ask about the residence. You want to ask about the illnesses of the mother during the pregnancy, because this could be a congenital illness. Then you also want to ask about details of their breastfeeding, because they have started breastfeeding, but how often? Are they doing it very well? And the investigations also want to do full blood count with the differential, ESR and C-reactive protein, to rule out infections and monitor our hemoglobin levels. Remember, in your exam, write these things in full. Do not write them as abbreviations. Do not assume that the examiner knows. Serum bilirubin, ABO, and RH blood grouping, Coombs test, a direct Coombs test, as well as abdominal ultrasound. How I'm going to manage this child: admit the child, investigate them, treat the underlying cause, give them IV fluids, cover them on antibiotics, and then phototherapy if they have continued rising of the unconjugated hyperbilirubinemia. Remember, we do not give phototherapy with conjugated hyperbilirubinemia because there's a risk of having bronze baby syndrome. Then the complications this child may have are kernicterus, which is damage to the basal ganglia, as well as cerebral palsy. Question 6. 2-year-old Michello presents to the clinic with a history of weakness and refusing to eat for 3 weeks. He and his sister were treated for measles 4 weeks ago. Mother has noticed that he has lost weight and some diarrhea, which stopped 2 days ago. There are no other complaints. On examination, Michello looks very wasted with skin discoloration on his chest and abdomen. He is alert but miserable. He has no pallor, jaundice, or cyanosis. He has swelling of both legs up to the mid-tibia and on the hands and face. His auxiliary temperature is 35.3 and he weighs 6.5 kg and is 74 centimeters. He is also refusing to open his eyes to be examined. RBS is 2.9 millimoles per liter. All other vitals are within the normal range for his age. Using the table provided, what is the standard deviation for Michello's weight for height? See the next slide. What is his diagnosis and why? How will you initially manage Michello? Use the critical pathway chart provided. So take a screenshot of this so that you can keep the clinical history in mind as we're answering the questions. And here is the standard deviation chart. On this side here we have for boys, on this side here we have for girls. Remember, Michello is a boy, so we're using this side over here. Then here's the critical care pathway. Also, you may take a screenshot of this and actually going to use this and actually fill it up. Very, very important, especially for the final year students. Okay, so here comes the answer. So this child here is at 74 and they are weighing 6.5. So we go like that: 9.6, no; 8.8, no; 8, 7.2. Here is 6.4 is the cutoff point for you to go now below -4 SD. So it means this child is falling between -4 to -3. So that's is less than -3 SD for the weight for height. So this child is going to be less than -3 for the standard deviation. So this child has severe acute malnutrition because he has a weight for height that's less than -3 SD, and he has bilateral edema. Of course, the edema is your 2+ edema. So remember, edema is graded grade 0, grade 1, or mild, moderate, and severe. So that's 1+, 2+, and 3+. So he's at 2+. Then of course, how will you manage Michello? So you're going to admit the patient, manage hypoglycemia, manage hypothermia, cover on antibiotics, monitor electrolytes, rehydrate him, and start early feeds. So we're going to be using the critical care pathway, which I'll show you just now. So here you put the name. Of course, Michello is male, he's 2 years, so you can put the date of birth if you have this. I'll put this at the time of, or the date of recording, that's the 5th, today, and the time about 15 hours. Then of course, if there's any pre-treatment that was given, there was nothing according to the question. In the question, they did tell us that he has some signs of wasting, so he does. Edema is at 2+, dermatosis are present, he had some pigmentations. Then his weight is 6.5, his height is 74 centimeters. Of course, the standard deviation is -3 SD, and his temperature, axillary temperature is actually not even minus, 35.3. This is not, ignore the minus here, it's supposed to be 35.3. Then our blood glucose is 2.9. Of course, his blood glucose is less than 3, so we're going to be 5 mils multiplied by 6.5, so we give him about 32.5 mils of course, your 10% glucose, 10% dextrose. Remember, we avoid 50% dextrose in pediatrics because there's a high risk of thrombophlebitis. Then, of course, the time that we give this, maybe we give this at around 15:10. We can give this IV if we're able to gain venous access. We're not so sure about the hemoglobin levels. We're not yet given that. Even the blood type, we're not yet given that. This child has a history of measles, yes. Eye signs, we're unable to examine him, so we can't fill this and we can't really guess. But he is above 12 months, so we'll give him 200,000 international units. When we come here, the only sign that we were actually told is that he's lethargic. We didn't have anything else, but in case that he was in shock, then we'll say 6.5 multiplied by 15, and that's how much you give. But he's had a history of diarrhea, no history of vomiting, no history of blood and stool, and only has lethargy, so we're going to be giving 6.5 multiplied by 5. That's about 32.5 mils of Rheumatic. And of course, how it's given is already indicated on this chart. Then of course, for the next 10 hours, we multiply 5 by 6.5, that gives us 32.5. We multiply 10 by 6.5, that gives us 65. So we give about 32.5 to 65 mils of Rheumatic, alternating with F75. We can fill in now the temperature, the respiratory rate, the pulse when we're giving these fluids. Same thing over here. We should also record the number of stool, the number of vomits, and the hydration status of this child, the amount of feed that is given. If we give any antibiotics, the drug, the dosage, the frequency, the duration, and the time of the first dose. That's pretty much how we fill in a critical care pathway chart for a malnutrition ward. I hope that makes a whole lot more sense. Moving on to question 7. A 12-year-old female from George compound developed painful right knee joint swelling, which after 4 days started to resolve and spread to involve the left ankle joint. She also had fever, fatigue, dyspnea. Physical examination showed BP 100/80, heart rate of 112 beats per minute, temperature of 38.3, axillary and respiratory rate of 26. What is the most likely diagnosis? Mention 3 possible physical findings you would elicit to make a complete diagnosis. List 5 investigations required for the diagnosis. Write down 3 risk factors for this condition. You may pause the video, and here comes the answer. So this child here has joint pain that is moving from the right knee, it moves to the ankle. So this child has, of course, a polymigratory arthralgia, and they have a fever. And they're within the bracket of the age range. So this child has rheumatic fever. The other features that they may have are erythema marginatum, synonym chorea. They may have subcutaneous nodules. Investigations that we want to do are anti-streptolysin and O titers, your throat swab, microscopic culture and sensitivity, your anti-DNase, beta antibodies, your anti-hyaluronidase antibodies, a full blood count with a differential which may show leukocytosis and anemia, ECG that may show prolonged PR interval, ESR and C-reactive proteins that may be increased. Of course, risk factors include the age between 5 to 15 years, the recurrent untreated throat infections, as well as overcrowding. Moving on to question 8. Peter, a 5-year-old boy, presents to hospital with a history of choking while feeding since 6 months of age. He has a history of having convulsions 6 to 9 months of age. He is unable to sit or talk. On examination, he is underweight, microcephalic, and spastic in all 4 limbs. What is the full diagnosis of this condition? What is Peter's full diagnosis? List 2 other possible causes of this condition. List the complications of this condition. You may pause the video, and here comes the answer. So this child has a spastic quadriplegic cerebral palsy because all 4 limbs are affected. The causes may be congenital, for example, torch infections, malformations, or acquired, for example, HIE, hypoxic ischemic encephalopathy, CNS infections, as well as trauma. Complications include learning disabilities. We do not want to refer to it as mental retardation, epilepsy, failure to thrive, visual impairments, even hearing impairments, as well as some respiratory problems like aspiration pneumonias. Moving on to question 9. Chansa, a 6-year-old girl, is referred from Kasisi. The family lives in a stream where they grow vegetables for some years. Very important to keep in mind. However, they had problems drinking water since the well ran dry. She has had few episodes of vomiting, fever, weakness for 10 days. On examination, her Glasgow Coma scale is 8 out of 15. She is pale and jaundiced. Write down 3 possible diagnoses. List down specific investigations to ascertain your diagnoses. So the 3 things that you're going to be keeping in mind, and here comes the answer. Remember that they're living near a stream. They're living near a body of water. So malaria, we can't rule that out. So severe malaria, it could be typhoid fever. It could also be hepatitis A, meaning that we're going to be ordering for things like a full blood count with a differential. They may show a high white blood cell count or a low HB, an RDT for malaria, a malaria parasite slide. We may order a wide antigen test. Blood, urine, and stool microscopic culture sensitivity. Liver function tests, so serum albumin, serum bilirubin, prothrombin and INR, liver enzymes like AST and ALT, and hepatitis viral panel. Now take note that I have listed liver function test and liver enzymes as 2 different things. Do not fall into the trap of confusing liver function test as being synonymous with liver enzymes. Question 10, and indeed the final. Chivale is a 2-year-old boy who's brought to the Pediatrics outpatient department with swelling of feet. He has sores in the mouth and has been coughing for the past 3 weeks. He weighs 7.5 kg. Assign the nutritional status to Chibala based on Wellcome classification. Write down 2 most likely differentials in relation with the short history. List down 6 investigations you would carry out to effectively manage Chibala's condition. What would the food of choice, in this case, you decide to admit Chibale, what is it made of? So you may pause the video, think through it, and here comes the answer. So our formula for expected weight, the newer formulas, or the newer formulae rather, which is 2 multiplied by the age, so 2 is a constant, so 2 multiplied by 2, that gives us 4, plus 8. So that's 12 kilograms. So this child is supposed to weigh 12 kilograms, but they don't. They weigh 7.5. So 7.5 divided by 12 multiplied by 100, that gives us 62%. They are greater than 60%, so they're within 60 to 80%. So the fact that they have edema, swelling of the feet, that means that they have kwashiorkor, according to the Wellcome classification. 2 things that we should not forget, TB and pneumonia. Of course, we cannot also forget, and we should keep in mind that HIV also could be a possible thing. We want to check out RBS, RDT, or malaria parasite slide, retroviral test, gastric lavage for acid-fast bacilli, or a urine lung for TB, then a full blood count with a differential, blood cultures, even our chest x-ray. Now we want to start them on F75, which is a low-calorie feed to prevent refeeding syndrome. Then it's going to be made up of 75 kilocalories per 100 ml of feed and about 0.9 grams of proteins per 100 ml of feed. I really hope that made some sense and helped you prepare for your exam. If it did, please show some support. Drop a like and drop a comment. Thank you for spending your time to watch through this video. I hope you really enjoy, and I hope we stay tuned for other episodes on the channel. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.